Hello, my name is Joe Mokai. Today I'm presenting a JJ 7 years old patient with comorbidity and other risk factor. Patient have family history of heart attack, social history of smoking, allergy to ACE inhibitor, angioedema. Patient has uncontrolled new onset, acute onset STEMI, objective of ST segment elevation, TIMI risk score, signs of hypokinesia and reduced ejection fraction of 38%, troponin is high. Subjective of patient complaining of heart attack. Party 2013-2004 ACC-AFA for management of PCI. EKG showed ST segment elevation in two contiguous greater than 0.2 MV lead V2, V3, V4, the interior wall left ventricle. Previous PCI for unstable angina, troponin is 68. This is STEMI, intermittent chest pain radiating throughout the chest to the shoulder and jaw. This is hypokinesia of the left ventricle. Patient had previous stroke. The risk factor: hypertension, age, smoking, type 2 diabetes, dyslipidemia, unstable angina, PCI, ischemic stroke due to ASCVD, depression, COPD, family history, sedimentary lifestyle, bad diet, obese male. Patient is on sildenafil. Patient is non-adherent therapy. Patient is willing to pursue therapy at this time. The goal is to reduce infra size, reduce body weight by 10% from baseline, smoking cessation, heart failure, target heart rate of 55 to 60 beat per minute, relief symptom, reduce mortality and mobility, target blood pressure less than 130/80. Prevent bleeding. PCI goal of medical contact to balloon or dot to balloon interval of within 90 minutes. So assessment of therapy include a calcium channel, dihydropyridine, amlodipine should be discontinued as not preferred by guideline. Aspirin 81 mg is suboptimal for PCI procedure. Whole tiotropium and albuterol includes heart rate. Patient is on sildenafil, discontinued sildenafil due to phosphodiuresis inhibitor within 24-48 hours of nitroglycerin. Party 2019-2004 guideline: patient require the following therapy: beta blocker and ACE inhibitor. Beta blocker decrease cardiac demand and MI progression. Initiate within 24-48 hours. It shows that reduce 14% of motility through 7 days. The BAR trial, the Capricorn trial, the Miami trial. The ABS is used in this place for a signs of left ventricular ejection fraction less than 40.40. So optimize heart rate and blood pressure. IV morphine for ischemic chest pain as needed for controlled pain. Oxygen greater than 90%. The recommendation is based on recommendation on discontinue amlodipine, sertraline, and sildenafil. Recommendation: continue atorvastatin 80 mg QD to optimize ASCVD. Recommendation 2: initiate metoprolol IV 5 mg over 2 minutes, 3 dose with 50 minutes interval. Recommendation 2 continues loading dose aspirin 350 mg PO once, a loading dose clopidogrel 200 mg PO once, vastatin 20 mg twice a day, titrate to target as tolerated, and enoxaparin IV bolus 30 mg plus 1 mg per kilogram maximum of 100 mg sub-Q 12 hours. Oxygen saturation greater than 90%. Nitroglycerin 5 microgram per minute, titrate IV until pain relief is obtained. Maximum is 200 microgram. IV morphine sulfate 2 mg to 4 mg can increase to 2 mg 2 to 8 mg. Repeat 5 to 50 mg dosing interval. PCMA 0.25 mg per kilogram IV bolus should be given, followed by 0.125 microgram per kilogram per minute infusion on 12-hour post-procedure. The rationale based on the 2013-2004 ACC and PCI is to reestablish coronary perfusion. This provides for at least 90% of STEMI patient. Result is the rate of STEMI flow range from 70 to 90, and 5% reocclusion rate after STEMI. Mobility and mortality from STEMI can be reduced significantly. PCI for the infrared artery within 12 hours of symptom onset, timely of balloon inflation within 90 minutes of presentation. The Essence and Synergic trial of eosinophil versus unfractionated heparin was used, and the comparison between enoxaparin and unfractionated heparin with the ATOL trial. The contingency plan and discharge plan include aspirin 81 mg POQD indefinitely, clopidogrel 75 mg daily for 12 months, vastatin 20 mg BID titrate to target, sublingual nitroglycerin 0.4 milligram every 5 minutes as needed for chest pain. Atorvastatin 80 milligram at bedtime for high intensity therapy. Start softener. The monitor, safety monitor include bleeding, hypertension, heart rate, EKG, stool GWA, hemoglobin, hemocrite, platelet, CBC, cholesterol, and bleeding. The safety monitor include relief of chest pain, angina symptom, target blood pressure less than 130/90, oxygen greater than 90, postprandial glucose less than 180. The non-pharmacological include smoking cessation of nicotine transdermal patch, and structural diet and exercise, of healthy weight loss. Then patient vaccination should include influenza, hepatitis B vaccine, pneumococcal vaccine, and patients should avoid NSAID and herbal supplement. Educate patient and multidisciplinary team for continual other therapy. Adherence therapy, bleeding and chest going, shortness of breath, nausea. Call 911 if unimproved or worsening after chest pain after 5 minutes of taking nitroglycerin in 3 doses. Patient have uncontrolled acute new onset decay, moderate. Patient is concerned of heart attack. As objective is glucose of 479 milligram per deciliter, positive ketone dehydration. Per the 2019 ADA hospital DK diabetes care, acute decay less than 24 hours. Blood glucose greater than 25 milligram meet diagnosis or criteria for DKA. Dehydration, dyspnea, dry mouth, positive ketone resistant insulin, anion gap. Risk factors include resistant insulin, type 2 diabetes, dyslipidemia, obesity, smoking, poor insulin control, STEMI, sertraline, stroke. The goal of therapy: restoration of circulatory volume and tissue perfusion, resolution of hypoglycemia and correction of electrolyte imbalance, correct ketosis and underlying decay causes, and target 180 postprandial and gap anion gap close. Plant therapy: continue metformin 1000 BID, discontinue insulin glycine with long acting and not appropriate per guideline. The rationale per the ADAD guideline: glucose greater than 24 require fluid and regular insulin to reverse glucose into the cell. The Ompazi G et al. Emergency ketoacidosis use of insulin and fluid to correct DKA. Plan include the C insulin glycine, continue metformin to improve insulin sensitivity. Recommendation: to initiate 1 to 2 liter of abnormal saline, 1 to 2 liter for 1 to 2 hour. Correction of sodium. So since sodium is less than 200, use 250 to 500 ml per liter for that. Insulin regular IV route bolus 0.1 to 0.14 unit per body weight, and continue with 0.1 unit per kilogram per body weight. If glucose does not fall in the first hour, give 0.14 unit per kilogram as IV bolus, then continue 0.1 unit per kilogram per hour. IV unit euglycemia target of less than 180 postprandial glucose. Glucose fall by 50 to 75% by 50 to 75 milligram per deciliter per hour, including infusion steady state. Decrease is achieved until is achieved. The rationale: using insulin and fluid to correct of acidosis, type 2 diabetes, hypoglycemia, ketoacidosis, insulin to facilitate glucose utilization and support ketoacidosis. The contingency: transition to sub-Q insulin. Start basal bolus 0.5 unit per kilogram per day. Overlap sub-Q insulin and insulin drip 1 to 2 hours. Basal insulin at bedtime or morning glycine, and a basal bolus, and consider GLP-1. Prevent recurrent ketoacidosis, rebound hypoglycemia. Monitor hypoglycemia, hypokalemia, magnesium, sodium complication, DPA fluid, and patient weight. Hypovolemic decrease, GFA arrow. Efficacy restriction on DKA, sodium correction. Measure sodium electrolyte, sodium bicarbonate, urea, chlorine. Monitor at least every 4 hours during initial resuscitation. Continue cardiac monitor. Non-pharmacological, including the sliding scale insulin. Educate patient on testing glucose and ketone level. Monitor based on previous recommendation and all that. Thank you very much for your attention, and other monitor will be included in subsequent and previous section.